All right, so welcome everyone. My name is Ellen Barra. I'm with our Provider Outreach and Education area of WPS, Government Health Administrators. Today we're going to talk about Medicare guidelines for routine foot care. On the call with me today is Karen Curtis, who is going to be watching our chat for us as we go through this presentation. Medicare guidelines for routine foot care do not only apply to podiatrists, but they apply to any specialty that is actually providing these services. So the first thing that we want to bring to your attention is just our disclaimer. We prepared this education as a tool for you to use. However, Medicare rules do change often. If you've been with Medicare and dealing with billing with Medicare for any length of time, you know that that certainly can happen. The CMS regulations and their rulings are always the final determinant of coverage, along with any documentation that you would have within your medical records. We will provide responses to questions based on the way that the question is asked to us. But of course, again, Medicare rules will determine that final coverage. And then Medicare does prohibit recording of the presentation for profit-making purposes. We are recording this presentation, and as long as the recording is fine, we will be placing this on our YouTube channel as an encore, and then you will also be able to access this from our website through the Encore player, so you can actually play the video actually on the website. And this should be available probably sometime within the next 2 weeks. So let's talk about what we're going to discuss today. We're going to provide information on what Medicare considers to be routine foot care and as such not payable by Medicare. We will provide information on the exceptions and what you'll need to have within your medical record documentation to show those exceptions. We'll discuss appropriate modifiers for the covered services, and we'll discuss what needs to appear on the claim itself when you're submitting to Medicare. Medicare guidelines on routine foot care are not specific to podiatry only. The rules and requirements apply to all provider specialties that actually provide this service. We had a pre-submitted question concerning a foot exam and whether or not it was payable separately from the routine foot care services. Medicare has a national coverage determination, which is 70.2.1, and the title of that is Services Provided for the Diagnosis and Treatment of Diabetic Sensory Neuropathy with Loss of Protective Sensation. We won't be covering that particular service during this presentation today. If you do want us to provide education on that, please indicate that in the survey. A foot exam not meeting the information within the national coverage determination would not be covered separately. In addition, if you are providing under that national coverage determination, you want to be sure and check the National Correct Coding Initiative guidelines for that. Another pre-submitted question we had was talking about wound care for podiatrists. We won't be talking about wound care in this presentation today. We are holding a wound care presentation for podiatrists specifically on Thursday. This is available for you to register on our website. You can go into the training section or training center and then go under the live events, and then you can register for the presentation we're doing on Thursday. So let's talk about who can actually provide these services. Nurse practitioners, MDs, DOs, podiatrists obviously can provide these. You can see also that a critical access hospital billing under method 2 A rural health clinic and a federally qualified health center can provide this. Another one that you'll notice on there is the registered nurse that holds a foot care certification. And you can see that certification listed there. Services provided by that registered nurse would have to be provided under the Incident to guidelines. So that means that that person would need to be an employee of the billing provider, and that service would have to be provided under the plan of care by that billing provider. We provided an Incident to presentation back in March, and this is available on our YouTube channel as an encore presentation, so you can certainly go and take a look at that. For the Method to Critical Access Hospital, you would submit these services on the CMS 1500 form or the 837P electronic claim. For an RHC, the service is considered an encounter when provided by the practitioners within your office. This is part of your all-inclusive rate. If the service is provided by your nursing staff, then this would go under the Incident to guidelines, and there would not be separate payment for that. For the federally qualified health centers, there are two procedure codes that you would use. One is the G0466 for your new patient, and then for your established patients, you would use the G0467, along with the specific procedure codes to reflect the service that you have provided. And this is paid under the prospective payment system. So let's talk about what are never covered services under Medicare. You can see here that treatment of flat foot is not a covered service. Subluxation of the foot is also not covered unless you have to do treatment for a condition that's causing that displacement, such as the osteoarthritis that's listed there. Your documentation must show the medical necessity of that treatment that goes along with the treatment of that underlying condition. Subluxation of the ankle joint can be a payable service. So let's talk about what's included in routine foot care. These are services that the patient and or their caregiver or a commercial entity can actually perform. You know, people go get a pedicure, you know, the mani-pedis all the time. So for routine foot care, then you can see it's cutting and removal of corns and calluses, trimming, debriding of nails, etc., hygienic or maintenance therapy of ambulatory or bedfast patients, and then shaving, paring, cutting, removal of the keratomas, etc. So again, for the most part, people can do these services for themselves. The patient's condition itself would not require a skilled person to actually provide the service. Now, if the patient is doing orthopedic shoes or supportive devices, Medicare would not pay for this unless it's part of a covered leg brace. The basis for coverage of or non-coverage of the service is based on the service, not the provider's specialty. So here's a question for you. If you're providing one of the services that are listed on this page and the patient is coming to you because they really would prefer you to do it as opposed to having it done commercially or doing it themselves, do you have to provide a Medicare beneficiary notice, or I'm sorry, a Medicare advanced beneficiary notice of non-coverage to this patient? Well, you don't. These are never covered services by Medicare. It's not part of the patient's Medicare benefit. And therefore, while you can provide an ABN, the Advanced Beneficiary Notice of Non-Coverage, on a voluntary basis if you choose, It's not required by Medicare. We'll discuss how you can submit the non-covered services using a modifier on our next slide. So if you're providing these routine foot care services and it does not meet an exception, again, you can provide a voluntary ABN just to let the patient know that Medicare does not cover this, but you're not required to do so. If you do provide one, you can append the modifier GX. This service will then deny as patient liability. You have indicated that you've issued the voluntary notice of liability, and you're indicating to us that this is a never covered service by Medicare. Modifier GY shows the service is statutorily excluded. It's not a Medicare benefit. What you want to think about with these two modifiers is that the procedure codes used to identify the services are the same, whether they're payable or not. So you could have a patient that does not meet the exceptions to routine foot care, and you would still be using the same codes as if you're treating a patient that does meet the exceptions. So that's when you really want to use these modifiers. The modifier GY especially tells us that you know this service is statutorily excluded, and therefore Medicare will deny that, and it will be denied as patient liability. You can use the GX and the GY together if you choose to. That's just notifying Medicare that you have done that voluntary notice of liability. Now, there are exceptions. So Medicare can allow routine foot care services in very specific circumstances. And that's generally going to be when there's other things going on with the patient that medically requires these services and requires a professional, a medical professional to be providing these rather than the patient or caregiver themselves or to receive these services commercially. So necessary and integral. So let's talk about that one. An example of this would be you need to apply a cast to the patient. And before you can, you need to trim those patient's nails. Well, you would need to access that National Correct Coding Initiative file to determine whether or not you could submit this separately. The routine foot care services could be considered part of the surgery code or the application of the cast code that you're using as that main procedure compared to the trimming of the nail codes itself. Treatment of warts on the foot would follow the same guidelines as treatment on the warts anywhere else on the body. The documentation must show the medical necessity for the removal, not just that it's there and the patient wants it gone, but that there's a medical reason for doing that. And then the next one there is the systemic conditions. This is where the patient has something else going on that makes routine foot care dangerous for them to do for themselves. They really need to have a medically skilled personnel provide this service, again, as opposed to themselves or commercially. And we'll discuss those systemic conditions in more detail in just a second. The last one there is mycotic nails, and we'll discuss those in more detail in just a second also. So the next slide that we have is talking about skin lesions, paring, cutting, removal, etc. The basic treatments of plantar warts is considered routine foot care. Once the treatment involves freezing or cutting, then it can move from routine foot care and a non-covered service into a service that Medicare can make payment for. Payment would depend on the medical necessity as shown within the medical record. Now, you also want to pay attention to those procedure codes and to those definitions. As you can see here on your slide, The 11055 is a single lesion. So this then would, of course, be 1 unit of service. The 11056 is 2 to 4 lesions. This is also 1 unit of service. If you have more than 4, you would use the 11057, and this is also just 1 unit of service. Using an incorrect unit of service can result in denials. And this is for the services that you would be providing on the encounter with that patient. You would not use any lateral modifiers such as right or left, or your T modifiers for your toes to allow additional services. And these codes, of course, are not restricted to the foot only. They could apply anywhere on the body. The next one that we have then are your procedure codes for the nails. And you can see the first one there, the 11719, trimming of non-dystrophic nails, any number. And then the 11720, 11721, these are debridement of nails, either 1 to 5 or 6 or more. And then the G0127 is the trimming of dystrophic nails, any number. So let's talk about, are we trimming or are we debriding? Well, what you want to look at is, what did your physician or practitioner or the clinical staff actually do? Trimming is going to be a reduction in the length of the nail. Now, debridement is a little more extensive than that. You're removing not only the length, but could also be the width. This is without going into the nail plate, however. Debridement is also reducing the thickness and the bulk of the nail. You want to watch your medical record to determine exactly what your physician or practitioner is actually doing for that patient. And you want to think about it. When we're doing our nails at home, we may use an emery board for an example. This is reducing the thickness or the bulk. We also may be removing debris from under the nail. The medical record must be very clear to show why this person needed the skills services today rather than being able to do this for themselves or getting this done commercially. Now let's talk about systemic conditions. These are underlying conditions that the patient has. The podiatrist more than likely is not going to be treating these conditions. The other practitioner who may be doing these services could be treating these underlying conditions. Because of the condition, the service may pose a hazard to that patient without the skilled service. And then some diagnoses do have an asterisk next to them. I'm going to take you to some information real quick in the show. What I have up for you on your screen right now, and Karen, let me know if it didn't come up. This is the information. Go ahead.
Ellen, we're still seeing the PowerPoint.
Okay. Let me stop sharing, and then we will share again. Go. There we go. Okay.
Okay.
Are you?
Yep,
Thank
we
you.
can see it.
I appreciate that. All right, so what we have up on the screen right now is actually from the Internet Only Manual, and you have the reference for that in your resources guide at the end of this presentation. And so these are systemic conditions that can justify coverage of the routine foot care services and can allow them to be payable. Now, you'll notice on here, hang on one second. You'll notice on here that, like the first one there, the diabetes mellitus has an asterisk next to it. And the arterial sclerosis next one does not. Well, those asterisks mean something. And what they're talking about is that there's additional information that you would need to have on your claim form in order to use that as a diagnosis itself, or as a reason why you're receiving, the patient is receiving the routine foot care. So you can see down here also, when the patient's condition is one that's designated by an asterisk, routine foot care is only covered if the patient is under active care of a doctor of medicine or osteopathy who documents the condition. So what are we talking about there? Well, what we're talking about is that, for an example, with the diabetes, the patient is receiving care for that diabetes from an MD or a DO. And if you're the one providing the foot care services, then you need to have that information. You need to know who's treating that, when was the last time that the patient saw that treating practitioner for that systemic condition, etc. So now I'm going to stop sharing and go back to our PowerPoint. Whoop, one more. So what I've included on this slide for you are just some of the examples, and kind of just to show the fact that some of them do have the asterisk and some of them do not. Obviously, we just saw the list that's actually in the internet only manual. This is not an all-inclusive list. Again, documentation has to support why the patient needed that service. So the asterisk really means that the claim is going to require additional information. Again, we talked about active treatment. That means the patient is receiving ongoing care for that disease that has the asterisk. The care does have to be by an MD or DO, and that patient needs to have seen that MD or DO within the previous 6 months. We understand that more patients, especially in rural areas, are being treated by nurse practitioners or other non-physician practitioners. However, we've looked and we can't find any CMS exception to it being an MD or a DO that's treating that patient. Patient does have to be seen within the previous 6 months. This is from the date of that routine foot care service. Now, you can accept the information that the patient provides to you. So if they tell you, I don't remember the last date I saw them, but it was in the previous 6 months, document that. Document that that's the information that the patient gave you, and then you're good. If you choose to, you can contact that MD or DO to actually see when the last time that they saw that patient. Your claim will need to include the NPI number or National Provider Identifier of the MD or the DO that's actually treating the patient. And then your claim will also include the date that your patient last saw that MD or DO for the treatment of the condition. We do understand that there are some other Medicare administrative contractors that are allowing the systemic conditions notated with those asterisks to be under active treatment by a non-physician practitioner. We're currently in conversations through a collective work group on that issue. We're trying to figure out, where did that come from that they're allowing that? Did they receive something from CMS that we did not receive? We don't know what the situation is right now. But if we make any changes, then we will, this will be published as a change to our local coverage article. And then all of the attendees for today, we would send that out to you specifically. However, as of right now, the information for WPS is based on what is in the CMS rules and regulations, and it does require that active treatment to be under an MD or a DO. We also have what are called class findings. And class findings is information that you have within your medical record that can also help you to show that these services should be provided by a skilled professional, skilled medical professional, as opposed to by anyone else. So the first one that we have there is the Class A findings. And this is a non-traumatic amputation of the foot. Non-traumatic obviously means that it's not an accident or something that has caused that amputation. So in your documentation, you would have to show the nature of that amputation, and this would include the where, how much of the foot was actually amputated, why was it amputated, and then when did that happen. The next thing that we have then are the Class B findings. And you can see that there's three main bullet points: an absent posterior tibial pulse, absent dorsalis pedis pulse, and then that second one is advanced trophic changes. Now, if you're using that second bullet as part of these Class B findings, 3 of the secondary bullet points are going to be required within your documentation. And you can see their hair growth, decrease or absence, nail changes, pigmentary changes, skin texture, skin color, etc. So at least 3 of those would need to be documented within your medical record. And so what you would want to have in there is not just hair growth, but you would want to indicate the patient has a decrease in hair growth and how you're determining that, or they have no hair on their feet whatsoever. Same thing with the skin color. You need to identify that and then any changes that have happened since the last time you saw the patient. And then same thing with skin texture or the pigmentary changes. You want your documentation to support this. You don't want to simply have like standardized language or something like that. It needs to be specific to that patient. And then the next thing that we have are the Class C findings. And again, this would be part of your medical record. You can see their temperature changes, edema. If you're using edema, then you need to identify the qualification of the edema, how much edema is there, how long has it lasted, etc. And then temperature changes or burning sensations within the foot. And then the next thing that we have are the modifiers that go along with those class findings. So you can see there the Q7 goes with a Class A, the Q8 is 2 of the Class B findings, and the Q9 is 1 Class B finding and then 2 Class C findings. And then, of course, the use of that modifier, as we've kind of stressed throughout this presentation, does have to be supported by the documentation in the medical record. And again, that medical record needs to be clear as to why the services should be provided by a skilled medical professional as opposed to the patient or a commercial service. So now let's switch gears just for a minute and let's talk about mycotic nails. Medicare can cover mycotic nails under 2 different categories. One is under the systemic conditions, and those are what we have talked about, the list of those, whether or not it has an asterisk, whether or not it meets the class findings, etc. You can also have coverage for treatment of mycotic nails for non-systemic patients. And so what you would need to have then are 2 things, and both of these have to be documented. You have to have clinical evidence of the mycosis of the nail. Now, this can be testing if you choose to do that. It can also be documentation of that clinician's judgment on the fact that the patient has mycosis of the nails. And then in addition to that, you also have to have that the patient has a marked limitation of ambulation. The documentation needs to show how that patient's ambulation is reduced, and you want to be specific. Based on the mycotic nails, the patient can't walk more than 15 feet, or they can't, uh, walk to the bathroom, whatever the situation is. You also want to identify when you're talking about the marked limitation of ambulation. Is the problem with the nails? Is it causing additional problems? So is it causing pain in their hip because of how they're having to place their foot so that they can walk? Those are all pieces of information you want to include. Again, you want to be specific. When we're talking about pain, you want to identify that patient's pain on a pain scale, and then identify any secondary infection, and then your treatment plan for that. If you're a podiatrist, for an example, and you're not going to be treating that secondary infection, then you need to have information within your medical record as to who is treating that, and then the way that that provider and yourself, how you are working together for that patient's situation. For non-ambulatory patients, these are patients who are going to be bedbound. Obviously, if they're bedbound, they're not going to be ambulating anyway. But again, you need to identify that pain on a pain scale, and then identify any secondary infection that the patient may have. Now, Medicare does have a frequency limitation on the routine foot care services, and that is once every 60 days. Medicare will deny services if they are provided more frequently. If you're providing services more frequently, you will want to provide that patient with that advanced beneficiary notice of non-coverage, and this will be the non-voluntary use of that. So to kind of recap that, if you're providing routine foot care services and the patient does not have any of the exceptions, you don't have to provide an ABN. If your patient meets the exceptions, and so it's a coverable service by Medicare, but your services are exceeding the allowed frequency, then you are required to provide that ABN. So we have information about the form here. Services, again, are covered by Medicare. The provision of the service exceeds the frequency limitation, and then you're providing that notice to the patient. We have an MLN, which is a CMS document within the resource section that provides instructions for completing the ABN. We also have information, in fact, we have 2 YouTube videos where we have gone over the ABN itself, the information that needs to be provided on there, and then also the modifiers that you can use. Karen has placed the link to our YouTube channel in the chat, and you can use that link and then simply do a search under ABN, and then those 2 videos will come up, and it will go into much more detail than what we can do today. However, a couple of things that you want to keep in mind when you're issuing this non-voluntary ABN, you do need to be very specific be very specific in your information on that form. One of the things that's required there is the reason for denial. Now, we had a provider one time who decided that he really didn't like Medicare. And so what this provider decided to do was to issue an ABN to every single patient. Number one, that's incorrect. And then in the reason for denial, the statement that this provider used, and I'm quoting, is that Medicare's crazy. I never know what they're going to do. End quote. Well, this really didn't help them anything. I mean, it let us know that Medicare, they weren't happy with Medicare. However, we then invalidated all of the ABNs that provider had issued. Number one, if you're issuing an ABN to all patients, then what you're telling us is that all of your services are not covered by Medicare. That's going to set off red flags for Medicare. In addition to that, the ABN is designed to be transparent to the patient so that they understand why Medicare is going to deny this and the fact that they are going to be then liable for the service. So I encourage you to take a look at those two YouTube videos that we have. Again, you can go into the YouTube channel and do a search at just using ABN and you'll get to those. These are the two modifiers that go with using or with the ABN with services that are covered by Medicare, but they don't meet a particular requirement. In the case of routine foot care services, this is frequency only. So the use of the GA modifier shows that you have provided that patient with the required ABN. Now remember, routine foot care, this is frequency only. If you're providing it in a non-voluntary, or I'm sorry, if you're providing it under a voluntary manner, then you would use that GX modifier. The claim will come in, it will process as normal. If we need to deny it, then it would be patient liability. Now, the GZ modifier works a little bit differently. What it's telling us there is that, again, you expect the service to be denied based on the frequency, but you did not provide the patient with that notification. When you use the GZ, we will auto-deny the service as provider liability. If submitting this GZ modifier on a claim, we would not expect you to request an appeal because you're telling us on the claim you already know that it's expected to be denied, but you simply didn't give the patient an ABN. Again, a couple of things to think about. Don't provide it as routine. Don't give one to all patients. And then you do want to be very specific in the information that you're providing on that ABN itself. So the next thing that we have are just some resources for you. The first one there is a local coverage article, which is specific to WPS on billing and coding foot care. Then we have information from the Internet Only Manual, and this is in the Medicare Benefit Policy Manual, Chapter 15, Section 290, which is the manual section that we looked at that goes through all of the information on routine foot care. The Code of Federal Regulations, or the 42 CFR 411.15, these identify that foot care services are excluded from Medicare. And then we have an LCD and an LCA on removal of benign skin lesions. We also have completed a targeted probe and educate on nail debridement, and we have provided a link for you there so that you can go and take a look at what we found in doing that targeted probe and educate. There's the MLN concerning the advance written notices of non-coverage. Then we include the class findings modifier fact sheet and the toe modifier fact sheets. Now the modifier KX works a little bit differently in the fact that there are some podiatrists who have received additional training, and because of that additional training, the state, whatever state they're in, also allows them to provide services to the hand. So if you're in that situation, you want to take a look at that fact sheet so you can identify if you're doing something, if you're a podiatrist and you're doing something to the hand under your state regulations, then you can append that modifier KX to the claim itself. The next thing that we're going to do then is take questions. We did have a pre-submitted question about where you indicate that attending physician when you're submitting on the UB04 form or the 837I institutional claim. And this is in field locator section 78. So Karen, I'll go ahead and turn it over to you for our questions.
Okay, thanks for all that great information, Ellen. We have gotten a few questions here in the chat. The first one is if a provider cuts toenails not due to a mycotic nails, but due to the patient asking, maybe due to limited mobility, would an ABN be required?
No, an ABN would not be required there because remember, foot care services are not a Medicare benefit. They're specifically excluded from the Medicare benefits. There are exceptions, which we talked about, but if you have a patient coming in and saying, I'd rather you do it than me do it, then you can provide them a voluntary ABN. You're required to bill Medicare if that patient asks you to. And then if you do, then you'll just submit that GY modifier to tell us that this service is not covered by Medicare.
Great. Okay, the next question we have is what proof in the documentation is necessary to show the patient has peripheral vascular disease? Do you need to perform a Doppler?
That's not a question that I can answer for you. You would have to have documentation to show that that patient has that. And there could be multiple ways that you could document the patient has that particular illness. So that's not something I can provide to you.
Okay, our next question also has to do with documentation. It says if documentation states non-palatable pulse, would that qualify as an absent pulse for the Q8, or must it specifically say absent in the note?
Well, that's kind of, you know, depending on the words that you're using. If you can't find the pulse, then you would not be able, you would have an absent pulse. You know, the non whatever word that was used there, I can't say it today. If your patient has edema as such that you know kind of can't get down to the pulse to determine whether they actually have one, document that. But again, if you can't find the pulse, then document that.
Okay, our next question is if a patient has peripheral vascular disease, must you include PCP last date of service in the billing or note?
If the peripheral vascular disease is listed with an asterisk, then yes, you would need to have that information. You wouldn't necessarily need to have it within the note itself, although that's a good place to keep it. But you do have to be able to put your hands on it because number one, you're going to be submitting it on your claim form. And then number two, should Medicare request that information, excuse me, you would need to provide it to us.
Okay, our next question I just want you to verify this, Ellen. Angie said, so uh, it cannot be an NP who last saw the patient for the systemic condition. It must be an MD or a DO.
That is correct. The information contained within the Internet Only Manual, and I had showed you that, specifically says MD or DO. A lot of times CMS can use information and they use the term physician, and they actually mean physicians and non-physician practitioners. For this particular section, they did not do that. They actually used MD or DO. So that's what we're requiring. The patient has to be under active treatment of an MD or a DO. Again, I want to remind you, we're aware that there are other Medicare contractors that are not applying it that way, and we are in conversations right now to figure out why they're not. And if there's something from CMS that they have that we don't have for some reason, that allows them to do that, then we will be updating our information and we'll notify you. As of right now, WPS is requiring MD or DO.
Okay, we did get a couple questions, so I'm going to kind of put these two together. If a patient did not know the last date that they were seen, but they know it was within the last 6 months, um, how do you determine the date to add to the claim as the last visit date?
Well, your best practice is going to be to contact that MD or DO and find out when the patient was actually last seen. You're not required to do that. If the patient can provide you with what they believe is their estimation of the date, you can use that. If you have that type of situation, though, be sure and document this is what the patient gave me. This is the information coming from the patient. Because Medicare can look at that 6-month time frame. If you have documentation as to where you got that, then that's something that our reviewers can consider.
Okay, when you were talking about the class findings, are those applicable to general practitioners or is it just podiatrists?
No, the class findings and all of the things we have talked about today apply regardless of your specialty. So if you're a family practice and you're doing this service for your patient, everything that we have talked about today applies to you also, other than you need to provide the MD or DO who's treating the systemic condition, because that's probably you. If it's not you, then yes, you need to provide that also.
Okay, this one, I don't know if you'll want to go back to the slide or not, Ellen, but for a Class A modifier, can you mention again what needs to be in the note? They could remember where's the amputation is, how much of the foot was amputated, and when it was amputated, but they couldn't remember that last bullet.
The other part of it is why. Remember, this is a Class A finding is a non-traumatic amputation. So, nothing fell on the foot and, cut part of it off. But it's a non-traumatic amputation. So you have to have the where, how much of the foot was amputated, and then when it happened, and specifically, why did it happen? Why did the patient need to lose part of their foot?
Okay. Will Medicare deny if you bill for fungal nails with correct information, but also add the class findings modifier? So one of the Q modifiers.
Okay, give me 1 second here. I need to look at the codes. Medicare would not deny for that if you have the class findings and you're doing the procedure codes that go along with trimming or debridement of the nails. Medicare would not deny if you're using those class findings in addition to the information on the mycotic nails.
Okay. And, oh, two more. Is the GZ modifier for all services or just for lab?
The GZ modifier applies to all services. If you know that Medicare, if you're expecting that Medicare is going to deny, and for the services we're talking about here today, that is based on the frequency. So if you know that you have provided that service more than once in a 60-day time frame, you can append that GZ, and what that tells Medicare is you're expecting a denial. You did not provide the patient with an ABN. So when that comes in, Medicare will deny that, and we will deny that as provider liability.
Okay, this next one I don't know if you're going to be able to answer because it has to deal with Part B or Part C insurances. It says, how do we bill RFC to Part C insurances that deny as a CO instead of a PR like Medicare does, or is there documentation that can be reviewed?
Yeah, unfortunately, that's not something that we can help you with. The Medicare Advantage plans, the Part C, are supposed to go along with the Medicare rules and regulations. If they're denying this as your responsibility, as opposed to the patient's responsibility, when it really is routine foot care, one of the suggestions I would have for you is to include either that GX or the GY modifier, because again, remember what I stated earlier, the procedure codes are the same, whether it's a covered or non-covered service. That GY modifier identifies that it's a never covered service. So that's what I would suggest to you. The other suggestion I would make to you is to go to that Medicare Advantage plan. And then if that doesn't work, I would go to your regional office for CMS. I think for our jurisdiction, it is in Chicago and in Kansas City, Missouri, and to see if they can assist you. Unfortunately, we don't have anything we can help you with on that.
Okay, next question is, you indicate an ABN is not necessary for routine foot care services. If we bill Medicare and Medicare denies the service, is it billable to the patient?
Yes. Yes, it is billable to the patient because it is not a Medicare benefit. Um, the same thing, and I'm using a kind of weird example here, but it's the same thing if you were cutting the patient's hair, for an example. That's not a Medicare benefit. Routine taking care of the patient's nails is not a Medicare benefit unless you have all of these exceptions and things that they've talked about. So you don't have to bill Medicare unless the patient asks you to. If they want you to, then you do have to. It's a requirement. But that's when you're going to use that GY modifier to tell Medicare that no, this is not a covered service by Medicare. This is never covered. It's not a benefit.
Okay, we do have one last question. Before I ask you the last question, I do want to remind everybody that these slides are downloadable on our live events page. I shared a link earlier, and I can share that again as Ellen goes through this last question. But the last question is what, and I don't know if you'll know this off the top of your head, what field on the 1500 does the last date seen by PCP go?
Oh, that's a very good question. Um, I know it's in the middle of the 1500 form. It's not box 19 on a 1500 form because that's where you're going to put your that MD or DO that's seeing the patient. I think it is, I don't know for sure. I'm thinking it's either 17 or 18 on the 1500 form itself. And it's actually titled, I believe, uh, date last seen, referral date, something along those lines. And that's where that information would go. You can contact, there's a couple of things you can do for that one. We have information on our website that talks about the 1500 claim form itself. There is also information in the internet only manuals, and it's 100-04, chapter 26. And so this is the claims processing manual, chapter 26, and it goes through each of the individual boxes on that 1500 form, and it will tell you in that chapter 26 exactly where that information goes.
Okay, you've gotten through all the questions, Ellen.
All right, wonderful, thank you. So on behalf of Karen and myself, again, we want to thank you for attending today. The questions and things that you provided were absolutely fantastic. We do encourage you to complete the survey. We want your feedback. If there's ways we can improve, please let us know that. If you thought the presentation was great, please let us know that also. This concludes our presentation. You can now disconnect. Thank you, everyone.